Welcome to the About podcast. Here we explore your financial health in simple and easy to understand ways.
Well, welcome back, everybody, to the About podcast, where we talk about all things your financial health. My name is Jeremy Scott, one of the hosts here, joined ably by Roy. Roy, how you doing?
I am wonderful. How are you, sir?
I am fantastic, and I am so excited. We have guests again.
We have a guest. I know you like this.
I do like
just chatting with me.
I see you a lot. We have a lot of conversations, which is good, and I love those episodes too. But it is always fun to welcome a guest. And today we have Jeannine Sucitu. Hello there. Welcome to the podcast.
Hello.
All right. And Jeannine, you are a critical care nurse.
Yes.
All right. So one of the things we talk a lot about, weirdly, maybe not weirdly, on this podcast is kind of end of life issues. And we've done a couple of episodes on that, but you are here because you have a rather unique perspective on it, doing what you do. So how about we give everybody just like the quick little bio on Jeannine, your expertise and why they are excited to hear this episode.
Well, I grew up in Johnstown.
Okay.
That's unique.
Not too many people actually.
Local.
There aren't too many actual locals. For those of you who are not in the Johnstown area, it's growing like crazy. Houses all over the place. So very few people feel like they're actually from here. Most of us are transplants, myself and Roy included.
Yeah, I've been a lot of different places since I graduated at Roosevelt High School back in 1998.
Wow.
So, yeah. I started out trying to go into childcare, really. Like I worked at a before and after school program during college. I also did volunteer work at the local veterinary office here, Full Circle Veterinary.
Oh, really? Okay.
I did that starting at like 14, I think I was there. So I was learning medicine and end-of-life care there too, because that's a big part of veterinary medicine.
Huge. People spend a lot of money on their animals.
They do. You know,
They also are neglected in the same way that sometimes humans are. So.
Yeah.
And I call them humans instead of people.
Yeah, that's probably right.
Because I think it's the veterinary background too, that they're human.
Yes.
Yeah.
The non-pets.
The non-pets.
Yeah.
And so I started out there, and then I realized I didn't like that part of it. I didn't like the putting down of animals for reasons that were, in my view, was almost unethical. There was some, we live in a farm community, which brings its own rancher ethics to the table. But when we take care of pets, sometimes just because we don't want them, we discard them. And that was part of that. And there was a lot of it. There was a lot of animals getting hit by cars and things like that just didn't sit right with me. So when I was at CSU, I was trying to get my microbiology degree there. I took an EMT class, and I was like, I'm going to go save lives.
There you go.
Instead of take them. And so my EMT instructor was like, you're not very good in people's homes, because I was freaking out inside at people's houses.
That's a big part of the job.
Yeah, I was good on scene calls. Like I loved the scene calls and taking care of people that were like in those high intense moments when the accident had just happened. But to get on into a person's house and then have to go in where there's drugs and guns and animals and things like that inside the house, I wasn't very good at. So my instructor was like, maybe you should be a nurse. Like you're a smart girl. Like you'll make more money doing that. You should definitely go to this information session.
Yeah.
And I didn't know what nurses did at that time. In EMT class, we had to follow a EMT tech in the hospital, and that was like my first like glimpse into what an ER nurse did and how they kind of run the show, and they run codes, and they know everything really that a doctor knows, because we have to catch doctors' mistakes. But we also have the caring part of it, which is a big part of nursing, is that we care. Doctors care too. And it's just we're the ones that are actually doing the physical caring of the patient. And so I went to get on a waiting list, a long waiting list back then, to get into nursing school. And then while I was waiting, I went and learned how to snowboard up in Keystone, and I used my EMT there to get in, but then I ended up not getting paid enough, like he said I would. And I started doing like reservations. I was like a wedding planner for a little while.
Wow, you've got a
I know I've
background.
got a lot in my background.
A lot of experience.
This was even before I was 23, 24. I went and lived in Washington State in an island off the Puget Sound there and did weddings. It was really awesome.
That'd be kind of fun.
And then I went into nursing school and
Where did
at
you go?
Front Range Community College.
Yeah.
So FRCC, it was a 3.5-year waiting list for me to get in.
Yeah.
Wow.
And we wonder why there's a nursing shortage now.
Yeah, that's a whole nother.
Yeah, it's a whole other thing.
podcast.
Yeah. So now you're in critical care. So why don't we kind
Little leap forward.
of how about what does that mean? Like,
Well,
if
I started out as a new grad in critical care, so I didn't even know really what it was. I didn't know what an art line was even, in which if there's critical care nurses out there, that we do that every day. And when I walked in after I got hired, I didn't even know what that was, which is like an arterial line that goes into your radial artery here to keep constant blood pressure tracking. So critical care is basically you're the sickest in the hospital. That's where you go. And there's a lot of people out there that have had family members, probably they went to the ICU. And as a nurse, we're part of that story. Everybody has a story of a family member going into either the emergency room or the ICU or critical care and saying, oh my gosh, they were in the hospital. And that's a family, like bringing down from generations. You know what that feels like for that one person to be in that hospital. And so we're a part of that every single day, multiple times a day, of that story of that family. And so when you go in, you're at high stress. The families are overwhelmed with everything that's going on and the concern of their loved one. And even though this happens all the time, like I've been doing this now, I've been a critical care nurse for about 19 years now, on and off with other things that nurses do. And I've seen a lot of people, and there's a pattern that goes through it too when they come in. So they're sick, they're dying, and we're trying to stop death is what critical care is.
Wow.
So to set the table for our listeners a little bit, I'm a financial planner. This is a financial podcast. You might be asking, like, why are we talking about this? But the reality is, as a planner, right? So my goal is to help people age with dignity. And as part of that, you help people make sure they have their financial documents in place, of course, but that also leaps into their medical documents. And one of the areas that I really help people get educated around is around their medical power of attorney and their living will. And, those are some of those decisions they have to think through in advance of who's my decision maker. Do I want my decision maker to be able to go around my decision, because you can give them that power, or do you want them to just follow your decision? Now, those are pretty straightforward decisions. Like, am I sick enough that I'm not going to get better, right? Or not? Like, that's the kind of big decisions we're talking about.
Right.
I would imagine, and I want clarity here from you, is, when you're in that critical care situation, the stress is created, of course, for the family members, but then what kind of decisions are having to be made? How does that work with the living will versus a medical power of attorney, and how does that all play together?
Well, it's a lot.
Yeah.
So when a family comes in, usually their loved one is already intubated, which means there's a tube that goes down into their trachea and helps their lungs breathe. So that's what a ventilator
So we have somebody in a position that's not able to be responsive
They are
or
not
make their own
decisional.
decisions.
Yeah, so they can't. Sometimes you can get them to come around, but that initial, usually admission to the ICU, they are not decisional. So we're keeping them alive with blood pressure medications and a ventilator. And sometimes we're feeding them externally, but that usually comes like a couple days down the road. So their first decision that they make when they come in is whether or not this is what they want to pursue. So when you're out in the field and you get brought in by EMS and something tragic happens to you, whether that's a heart attack, you pass out, you lose an airway, you're in a car accident, any of those, you're considered a full code. So a full code means that we're going to do everything in our power to keep you alive. And so that's where I know you guys have talked about DNRs, or do not resuscitate. We also, in the state of Colorado, you have to designate between do not intubate as well, which means
Really?
that tube that goes down into
Okay.
the ventilator. So you can be a DNR, which is a do not resuscitate, or a DNI, do not intubate, or you can be both.
And that's always a confusing point for clients too, because in the estate world, they're like, well, I like a DNR. I'm like, well, you actually have to have that from a doctor.
Yes.
Your estate planning documents don't typically provide that.
Yep.
You need to have that with a doctor.
Because it's a very intense conversation that they talk to you about all of the different things that they do when they do have to perform CPR or resuscitate you. So resuscitate is different than just CPR. When we resuscitate a human being, they're on the brink of death. We're performing chest compressions. We're pushing drugs, and we're cracking ribs and things like that, trying to keep you alive. And CPR, I don't know the facts off my top of my head. I just know that it's when we are successful, it's normally when the arrest happens and it's been seen. So if you're within a couple of minutes, because brain death happens after 3 minutes of no oxygen. And so if you're calling 911 and their response time is more than 3 minutes to get there and get you oxygen and get you what you need for the CPR, your brain is actively not getting the oxygen that it needs, and therefore it causes damage in your brain, which I don't know if anybody around here has had strokes or been around people with strokes. They have damage that's happened to their brain, and so that causes it causes a disability or something that they can't do with their brain later on. Right. And with hypoxia, which is what
a lot of times it's like speech or movement, or I've had plenty of people who've in
or
my churches who've had strokes, and
like you were not able to process things, brain fog. There's a lot of things that happen after you have no oxygen to your brain. Yeah. And so when you are a full code, or that we're doing everything for you, you might come back as a different person. Like you might not have the full capacity that you went under with. And so when you're in the hospital and they have that conversation with the family, that's something that we need to know, because at any moment that person could go into cardiac arrest because of the reason that they're in there, or for an underlying reason that they're in there. And then we're performing life-saving measures to keep this person alive, even though they might not be at the same capacity that they were before they went under. Yeah. So, yeah.
Yeah, unfortunately, I've seen it a lot, and it can be. And I honestly think sometimes, I think I've preached on this before, is that I think television has given us a skewed look on things like CPR, right? Like, something happens, they do CPR, and suddenly magically the person's fine and back to normal.
They cough up the water, and
I'm like, no, it's like, I was like, no, CPR just takes you back to that place right before you died. I mean, it doesn't like fix whatever caused you to need CPR in the first place. It's not this magic cure. So, and it is very invasive.
So those are the questions. Like when I first initially came to you guys about, maybe you guys need to have this conversation with the congregation, because you guys did a talk with the Methodist Church about financial stuff and then like funeral planning. Well, there's a step in between that causes a lot of pain and sorrow, and those are those conversations. And if you've just had that one conversation with your family member of, I want everything done, then the family member's like, that's it. I remember that conversation. We're going to do everything. But if you've had that other conversation where they're like, I don't want to be kept alive unless there's a chance.
Right. And that's actually the area that I have with a lot of people too, is that they think that they want something. But when I actually say, okay, let's just say this is what that means in implementation. Is that what you want? Oh, no, that's not what I want. I don't want that piece right there. Okay, well, we can talk about that and figure that out. But similarly for you, right? I want it all. Do you really? But what does that mean? So do you meet with people in advance of this? I mean, no,
because they're coming in and their loved one's already intubated.
Got it.
So then you have the family.
So I guess I was
meaning
more from your the institution you work for. Do they have any kind of like outreach that helps people?
Most of the time, it's the doctor. So your primary care doctor should be having these conversations with you. But it's easy just to say, "Oh, you want everything full code." And to set, and because this conversation that we're having right now, me explaining it to you, is more than usually a primary care doctor has time in their office to have that conversation.
Therein lies the problem. We got 10-minute appointments, and you got to get through 20.
Or your physical, and they're like, "No, you got 20 minutes for your yearly physical." Yeah. And this is a conversation that you need to have at any age too. It's not just like, "Oh, I'm retired." And
it's like, what do I want if I'm in this situation?
No, this is like, I have kids at home. I have little ones at home. And I'm driving to work and I get in a car accident. What should happen to me then? And most of the time people are like, well, we have kids, so I want everything. And then you're like, well, what about that partner that you have at home that they're going to be having to do total care on you while you're also taking care of those little ones at home? Like and this goes into theological, like it's a very emotional decision. And so if you've had even these little tiny conversations, like if I wasn't to come home tonight and I end up in the hospital, what do you think I would want? And then have that loved one talk to you about it,
right?
Because they might not even have any idea. And this is something that I know my family talks about all the time because it's my job and I bring it home. But I'm a newlywed still. Like in May, we'll be married for 4 years, and he is from a different country. He's from Romania, and his aspect on end of life care is completely different than what has been for me.
Oh.
And so he's not my durable power of attorney because he wants me to live
Pull the plug.
forever. And I'm like, no. But we've had that conversation.
Yeah. But there is, people do bring, all kinds of I don't want to say baggage because that's not quite the right word, but they bring all kinds of frameworks to it. And so it can be cultural. Yeah, there religious, connotations and frameworks, different religions, different, flavors even within Christianity have different thoughts on medical intervention in general, or, how far is, too far, and the sanctity of life and, all that kind of stuff. But, it's not just a quantity of life. There's a quality of life conversation. That's what I kind of hear you saying is that, you might get more days, but what kind of days will those be? And of course, in that moment, you don't know.
You have the doctor's
it's all
favorite
best
thing
guess.
Is, I don't have a crystal ball. Like that's the doctor's favorite thing to say when they're trying to have these conversations with people, because they're like, is he going to come out of it? And they're like, we don't know. Like, because they don't know. They don't. And they're always like, well, is there a miracle that might happen? And you're like, maybe. But when you even say maybe, then people hold on to that. And hope is the thing that gets us through crisis.
Right.
If we don't have hope, then there's only despair. And when there's no hope, then your decision making is completely different. But if you're using the facts that are in front of you and the things because people like percentages too, which doctors don't like to give.
Oh.
Because they don't really know.
Yeah,
everybody's different.
They're all made up.
I heard
there are
that,
real science
I heard
behind
that
things.
42% of percentages are made up.
42% of all statistics are made up. Yeah.
That's hilarious.
Yeah.
Yeah. So people like percentages
Yeah.
because that helps them make a decision. But the doctors are like, I can't tell you the percentage of what they're going to have. Because my real background is neuro ICU. So there's different types of ICUs. There's cardiac ICU, neuro ICU. There's medical ICU, surgical ICU. Mm-hmm. And my specialty was neuro ICU. Now I'm a float pool, so I go everywhere. But neuro ICU means that you have some sort of brain trauma to your brain. And what does that mean for the deficit? So we're doing neuro assessments like sometimes every 15 minutes on how sick these people are and the changes that might happen. And so they can tell you what part of the brain it is and what kind of damage it could be happening, but that also can increase your chances of having more damage later.
Yeah.
So when I think about end of life and I think about the conversations that I've had with families specifically, they're always thankful that they've had that conversation with their loved one beforehand. And the most damage that I've seen in families is when they don't have that conversation to fall back on. They don't have that one thing that they said that I can remember.
Right.
And I always say, like, when people are passing away, because I've also been at the bedside with a lot of patients that have passed. And I tell their family members, you will always remember what your mama said to you. You always have your mom's voice inside of you. You always have your dad's voice telling you what to do too, because you know what they're going to say before they say it, because you've been around them and you have that relationship with them. And that's the same thing with your loved ones. When you're not, or like your partner or your spouse, or you know what they're going to say before they say it. But sometimes this conversation, you don't know because you've never had it.
Right.
So you've had conversations about brushing your teeth and, checking your oil in your car and stuff like that.
Well, I mean, because you are literally making not only life and death decisions, you're making, which is hard enough for yourself. I think it's even harder when it's a life and death decision for somebody else that especially you care about deeply. There's so many layers on top of that. And most of us just want to do the quote unquote right thing, which is, for most of us, again, is probably whatever it is we reasonably believe they wanted. And if you don't know, then you don't know.
Yeah. And you also want to take all the information in that you're getting when you're at the hospital too.
Yeah.
So the doctors guide patients on some of the things that are happening, but it's still based on, is this patient going to die? Right? Like you asked, what's the first decision? And it's whether or not they're DNR or DNI. That's the first decision. But if you have this paperwork that's filled out ahead of time, like your medical durable power of attorney, which is different than financial, because a lot of people have that done. Like that is something that people have. They're like, oh yeah, I'm the power of attorney. And then you get the paperwork and you're like, no, this is financial.
Yep.
So those are two completely different things. And each state is different too, with who has a say in the care of the patient that's in the bed. We do love paperwork because that helps us make that decision, but anybody that knows that person can come in and help make that decision too. And so we reach out if we don't have a proxy, which is somebody that is going to be making those decisions. We reach out to people that know them. And some people come in and they don't have any family.
No.
So then where do you go with that? They lived here for 30 years in Colorado. They're a very independent person. But just the other day, we had somebody come in and he didn't have any family. He had no children. He had a niece and nephew that lived in New Hampshire and hadn't seen him in 15 years and had no idea what he wanted. And he's on a ventilator and sedated, and we can't wake him up. He's had a stroke and we don't know what to do because he's a full code to us. And so we do everything that is in our power to keep him alive. And then we end up extubating him. He has no verbal at all. Like he can't make words, but he can say yes and no, but he can't say words at all because of the stroke that happened to him.
Mm-hmm.
And so how do we know that that's really what he wants? And when you assess somebody in their neurological status, sometimes you think they're there, and then all of a sudden you're like, they probably should have said yes to that. And then you're like, wait a minute, but they should, because it's a yes or no question. Yes or no could mean a lot of different things. So you really have to dive into that assessment on them neurologically. But thank God they reached out to the nephew, and he was like, we can, but I really don't want to. So then I called an ethics consult, which is something in the hospital that we can do that I don't think is used enough in the state of Colorado, at least at the facilities that I've worked at. Before, when I lived in Michigan, we had ethics stewards that were part of the flow of patient care on the floors. And so if we had an ethical dilemma, which happens all the time in hospital settings, that we can raise the question, we don't think this is right. And it's based on principles in ethics like autonomy, division of care, things like that will help us make those decisions. But it's just somebody to come in and be like, look at all the different answers and why we're making the decisions that we're making and whether or not that is the right path that we should be on.
Yeah. I've had colleagues that have served on because sometimes they want clergy, sometimes they don't, but sometimes they don't mind having clergy around. But I've had pastor friends who've served on ethics councils for hospitals, and it is fascinating.
I love the ethics part of it. I really wanted to do bioethics as my advanced degree, but there's not a whole lot of jobs.
So two things. Have you ever seen the show The Pit?
Yeah. Well, it's hard for me to watch that because it is very, very real.
Well, I say, so everything you're explaining is like make me think of that show.
I'm sitting here doing the same thing.
HBO.
Yeah.
Well, for everybody that
I'm
doesn't
on
know.
episode 2 right now.
Of season 2?
No,
Of
season 1 because
geez.
that's how
it's
hard
intense.
it is for me to watch that show.
Yeah.
Well, so the point is, so you're in a very intense environment. You have not just one person to deal with, right? Like you probably have whatever's come in for that day or whatever period of time you're looking at, and then you're having to make decisions, quick decisions, realistically, right? Life-saving decisions. And so what you were saying with your fellow who was had a stroke and couldn't communicate, no family members that you knew of, when you're making decisions, that's the process that you go through is is this ethically what we should do or not if you don't have any guidance?
So that's kind of where I was going with the
Perfect.
ethics consult. So then I was like, then maybe we need a doctor proxy to be able to make the decisions for this person. And so if you don't have somebody that can make decisions, then they usually assign some sort of medical professional, which is usually a doctor, that is able to make those decisions for that person. But luckily they were able to find a whole group of friends, because he was a retired police officer or something like that.
Those guys
so
are
he
tight.
had a huge family network that wasn't really family, but they were able to help make those decisions. And he eventually, this is like, I don't want to give people false hope about stuff, but he did eventually come out of it and was able to start communicating in a different way because of the interventions that they did for his stroke. So, but at that time, we didn't have anybody to make the decisions.
Okay, so then for our listeners, if you have the ability to make some of these decisions in advance, you can name people through your medical power of attorney. You don't have a medical power of attorney, then you have to have essentially a hodgepodge of people that potentially care about you,
that
try
you don't
and
really
help out, right? So, I mean, I think that's important for our listeners to know. If you want to have some of this control and decision making, you've got to go through this. Like, so for instance, the medical power of attorney is pretty straightforward. It's just a legal document, right? But it doesn't really have what the decision-making piece of it, realistically. There's a couple of things in there. But the living will is the most important document, in my opinion, for having a conversation. Because when you have to have a conversation about if you're basically in a situation where you're not able to communicate, what do you want to happen in certain situations when you're in that situation? So you're forced to have that conversation at that point in time. And I think that's really important to have that conversation. Interestingly enough, I had a doctor recently tell me he didn't like living wills because he felt like they could be contradictory. But I'm like, I actually like them because it forces people to have the conversation.
The conversation, yeah.
Yep.
Yeah.
Of what they want to happen, which then is really important for the people who will be helping them.
Yeah.
You know, and if you don't have a loved one to help you, everybody has friends, you can name friends. And if not, then you talk to your doctor even so that they know it in advance and can maybe have that proxy design or however that works.
Yeah. A living will is kind of confusing sometimes because people bring those in, but really we just we truly rely on the durable medical power of attorney.
The power of
to
attorney
make
is the
those
legal
decisions.
document that actually guides the power, right?
But the living will helps you with the conversations like, do
Exactly.
you want tube feeds or do you want to be fed through a feeding tube, which also is kind of hard too, because some people don't understand what that means because it helps you heal.
Right.
And it's not like a life sustaining thing. Like food is not going to save your life, but it's going to help make you heal and maybe come out of it a little bit different.
So I'll tell you how intense this can be, right? So I actually had a client that was unfortunately in a situation where they weren't going to get better. And they had to get a power of attorney in place. They didn't have one, right? And they were still able to function. It was a cancer situation. But, it asks questions like, do you want to have your hand held? Do you want to have, music on, right? This is end of life stuff, right? So, what is the experience that you want to create? That is the conversation that I think you're really talking about, is having these family members know what's exactly going on. And that is actually the experience that I try to help people guide them to do and have that conversation, which is the worst conversation in the world they ever want to have. Like I have one client that will cry every time you talk about death, right? Like it's very difficult and emotional for people. So they don't want to, but would you rather have it tough, emotional conversation where you can prevent your loved one to have an undignified situation where people are fighting over their death or, what I mean? Or ruining relationships within the family over the death because, well, no, they said this to me. No, they said this to me. And now you have a conflict.
Better just have it written down.
That's right. At least have an open dialogue with the family, right? Then everybody hears the same conversation.
So having a conversation, getting these documents in place, making sure that, people know, somebody knows what it is that you want. I mean, I think that's, for most of the time, I think that's the biggest mistake people have, is not doing those things. Are there other kind of like common mistakes you see people making that you're just like, man, I wish they'd thought a little bit more about that, or poor assumptions that people come in? Because if you've not dealt with this yourself or with a loved one, right, the first time you end up in an ER situation where something's catastrophically gone wrong with somebody you care about, like that is a really jarring experience. It's every time, but especially if it's your first time.
Well,
so I mean, are there things you're like, man, I wish they knew this coming in, or
Okay, I'm gonna say stuff that might be controversial, and I'm sorry, but nurses say stuff that is hard to say.
Yes.
There was a comedian, Noah, something that said nurses are not nice. We're not nice people, but we are kind because we say the things and we tell you the things that you need to hear. And that's somebody that's kind that says that. Like if there's something in your teeth, I'm going to tell you.
Yeah.
But the nice person would be like, "Oh, you're beautiful. Everything's okay." That's not a nurse.
Yeah. Having lived with one for 20 years and my late wife, I can tell you that is absolutely true.
And I never thought that until it was like 2 weeks ago that I heard that saying, and I was like, that is true. We do the hard things. And so when we're sitting there and you have a 98-year-old grandma who you love and who is precious and amazing and has been totally with it for 98 years, she might even be living on her own, and she's a full code, which floors me because we're going to be doing compressions on this frail 98-year-old woman who will not survive the CPR, which is also something that happens when you're crushing somebody's rib cage at 98 years old. The chances of her getting pneumonia later on and dying is extremely high. Like, I don't know the percentages, like I was saying before, but it's so high that we keep you if you fall down and you break your rib, we keep you in the ICU over the age of 65 because the chances of pneumonia after a broken rib after 65 is drastically higher. So we keep you in the ICU so that we can do what we call aggressive pulmonary toileting to make you actually take these deep breaths because it hurts with every breath you take. But yet we're going to be doing compressions on this fragile woman, and the chances of her coming back out of us doing that is very, very low. And so I think that's the biggest mistake, that when professionals we're in the ICU and we're thinking, oh, this grandma is in here for a broken hip and she's still a full code. We don't understand that at all. Like we can't comprehend because we've seen it happen over and over and over and over again, even though that is their choice to be able to do that. And we will still do everything we can to save her. It just hurts us a little bit every time that we have to do that to somebody. And in the profession, this is a whole nother podcast too, is moral injury. And I don't know if that's something that you guys have talked about, but since COVID, the hospital staff, even all of healthcare, is suffering from something called moral injury. And that means that when we see something that is not right, and then we still have to go and do the thing that they're wanting us to do, like with COVID, not letting families have contact with loved ones when they're in the ICU and they are dying. That causes moral injury, not just to the staff that have to say no to it, but also to the family and then their trust in the healthcare profession as well. That causes moral injury to them being able to make the right decisions because they're not going to trust what we say, and they're not going to trust anything that comes from that finding. Just because we told them, no, you can't come see this person that is dying in the hospital. And that's not very long ago, right? That was 6 years ago.
Yeah.
So that's still so fresh in everybody's minds when they're making these decisions. And
That's season 1 of The Pit.
that's why it's hard for me to even talk about.
Yeah. Well, I think I know in my circles, like, especially when a lot of veterans started coming back from Iraq and Afghanistan, the concept of moral injury was really came to the forefront of, like, as a way of talking about, what veterans and stuff were dealing with, having been in situations to do things that they otherwise would not have wanted to do or, felt was right, but they were in a situation where they had to. And I think that kind of busted open that conversation about it. And now we're starting to see, like, that's not, definitely it's present for our veterans, but that's not the only place you find it. And I think healthcare, everybody's got a little, PTSD, that term's almost overused, and unfortunately anymore. But so you it's not only getting your understanding what you want and everything like that. It's peace of mind for your loved ones is doing the right thing. But it's also, so the healthcare professionals can know that they're doing the right thing because you want to do the right thing.
Well, we also know what a good death looks like. So I would like that to be something that everybody is able to have in their life.
Right.
I call it the bookends. So when somebody's born, it is gross. It's messy, but it's one of the most beautiful things that happens in our life, right? Is a birth of a child. It is gross,
Yes, it is.
but it is awesome.
Haven't been there twice.
And then you look at the end of life, and it's the same. It's gross. It's nasty, but it can be beautiful depending on how we make that happen. Yeah. And as a critical care nurse that has held hands during COVID, where I'm the only one in the room when somebody's passing, and I'm trying to make the iPad at the right angle for death, which is like weird because it's like a selfie, and it wasn't right. Like, these family members are in a different room across the hospital trying to help mourn that person and let them go on to their next journey. And something that's not right. That's not a beautiful death. And then you have this happened probably 3 months ago that it's a Catholic hospital system that I work in. I'm not Catholic, but it's a beautiful thing how they accept the end of life. And this woman said, no, I don't want this anymore. She decided to extubate herself because it was a respiratory thing, and she knew she was passing. And the priest came from her local church, and they sat in the room. They did the end of life rites. He sat there and sang hymnals until she passed away, and you could hear it echoing through the hallway. Oh. And it was stunning. And her family was there. They were. I'm getting goosebumps just thinking about it, because that's what it's supposed to be like. You're supposed to be able to have a say in it, first of all. Yeah. God has the most say in it, but you should be able to have that for your end of life and not make it be, I'm pushing on your chest, trying to keep you alive, and blood is everywhere, and urine and feces, and that is not a beautiful death. And if I think it's the acceptance that death is actually going to happen too, is a process that happens with family members when they're in that process. And so we let people see CPR at the end of life. We let them witness, because they need to know that we're doing everything we possibly can for their family member. But with that also comes pain, and the thought of you watching your loved one go through that in that bed, and what we have to do to keep them alive. It's messy, and it's hurtful, and it's harmful sometimes. And that's when they go, no more, is when that is. And that's it. That no should be a realization that happens before we're actually doing that harm to that patient, because that's also where the moral injury comes too, because we know we're causing harm when we're doing this to this person. But the right thing to do is to let the family members make that decision. Yep. And we can't pick and choose who we save lives, because that's definitely not right.
So you have definitely a passion around this and educating people about this. That's why you even talked to us, to me about it originally. And so for our listeners to take something away from this, realistically, it is, get the proper legal documents, of course. The living will, have that conversation. The DNI and the DNR, I think, are important. So we kind of roughly touched on that, but so for our listeners, what would be the best way for them to approach looking at their own DNI, DNR, and having that conversation? What should they do, and how should they approach their doctor?
You just say that I want to have a conversation about end of life and what that looks like for me, and the doctor will talk about DNR, DNI, full code. I'm still a full code because I feel like I want to be saved. I have children that will still want their mom, but I can only talk about it personally too, because everybody is going to have that conversation on their own, and everybody's going to be different. My parents, they don't want to be resuscitated now anymore, but that might come to a different conversation based on what's medically going on with them. And so like if I have a terminal illness that I'm diagnosed with, my conversation will be different at that time. And so every time you come into a doctor's office, I believe that they should be talking about your code status. And that's whether you're a healthy bodybuilder, 22-year-old person, they should still have that conversation with them.
So what does that look like? They need to schedule an appointment with their doctor to have that conversation?
You can do it at any doctor's appointment.
So they just need to bring it up, or they need to schedule it in advance?
Nope, they just need to bring it up, even if it's like at the urgent care, and because any doctor can change your code status at any time.
So does that go like in your record?
Yeah,
or?
it's like, so Epic is a system that a lot of the hospitals in the state of Colorado use, and all the charts talk to one another on my chart. And so once that is put in there as like the status, then we look it up every single time.
So then here's the question, because I have a lot of people that travel. So you're in a different state. How does that look? Do
So-
they have that access to that information?
Yeah, Epic is everywhere.
Well, but let's just say it's worst case, not an Epic system.
Oh,
What happens?
so they still have this thing called MyChart, which integrates with other systems.
So there's
now
potentially the access to that
to
information.
have that information. You can
and-
also, so most people, like when you go into hospice, they tell you to put the DNR order on the door. So when they go in, that the staff knows where it is, because they need to have that order in order to not perform CPR.
Mhm.
Even a tattoo on the chest that says "Do not resuscitate." We've had tattoos that have that, and we can't follow that because that's not a legal document. So, so it says DNR, but there's no legal document.
I have
so
a
we
lot
still
of
have to
clients
do
that
it.
travel internationally and things like that too. And it's funny, I was just watching a YouTube guy. It's like a food blogger guy. This was kind of fun. Well, he ended up having to have a surgery, an appendix in Myanmar. It's like, he's like, this is not what I expected to do, but it's like, he's by himself. He's got like a work member with him or something, and that's like a very obvious extreme situation. But
No, but it could happen to me. I think about this all the time because in the future, the plan is for me to move to Romania, and I'm terrified because I don't speak Romanian.
beautiful country.
It is.
Beautiful
It's
country.
stunning.
Lots of people speak
I
English
love
there.
it.
No
Yeah, they
worries.
do. But in the healthcare system, if
Duolingo,
I don't
baby. Duolingo. You got to get on it.
Yeah, get
it's
on
one
it.
of the hardest
Start every
languages to
day.
learn.
Every day.
Just so you know.
They have really good wine.
My wife's
over
been
there.
learning Italian, so I feel like I've just been
No,
learning it.
Italian, I know I could learn that.
Yeah.
But Romanian, like my brother knows 5 different languages, and he tried to do it, and he was like, "No, Jeannine, no, don't."
Do you do the new rule from 7 to 8 p.m. every night? Your husband only speaks to you.
He tries that, but then I get frustrated. So.
You're like, just speak English.
So going there and knowing the medical that I know, I would be like, what's going on? What's going on? And so we do have translators, but
Yeah.
I don't know if they would have that in another country, but you should carry your documents with you when you travel if you have something like that, so that they
It's a
will
good
be
point.
able to.
That's a really good point. Yep.
I think
Yeah.
so. Well,
Well, there's a lot to this. And,
Yeah.
and it's you mentioned it earlier, but it's like I like to let people age with dignity, right? And you said, well, yeah, I want to help people die with dignity. That's the comment you made, which
Yeah.
I think is a very, very noble thing. And then the other piece that we had to this already, it's on the podcast. I don't remember what episode it was, but it's basically having your body, disposed of with dignity, if you will,
Right.
and the family getting a dignified close. And
Yeah.
shout out to Chad Young of Young's Funeral Services.
I know
That's
you guys
right.
are neighbors.
that's right.
Yeah.
It's right across the hall over here.
Yeah, you guys, this is one-stop shopping over here at Roy's Place. So
That's right.
yeah, one of the things I think I think this is an important conversation. It is an uncomfortable one, but I think it's important. I know I've had it with families when they have diagnoses, especially if they're diagnosed with something like a cancer that doesn't have a good prognosis. And one of the things I'll try to weave into my pastoral care conversations is, where are you with, like, do you know? And
I also want to drop something in here. Palliative care is not hospice. Okay. So palliative care is for long-term diagnosis of any disease. That's diabetes, that's heart disease, that's COPD. And so I believe firmly that every person that has a long-term diagnosis should have a palliative care doctor on board, which means that they're taking care of your whole person, your whole being, and making you comfortable through that disease process. It is not hospice care.
Yes.
There you go. That's
Yeah.
what I wanted to make sure.
Hospice
everybody
is
knows.
actually another whole other topic.
We should get that.
We,
Yeah, that'd be
we
a good
probably
one.
need to get a
That'd be
hospice
good
one going.
We got
That's
lots
the
of
only
good
thing.
things coming,
But yeah, and the one thing I want to kind of just as we wrap up here say is, I was probably, and I don't know how it was for you when you got into professional life. What surprised you? I know for me, I was surprised how the first time I was with somebody when they died, which happens, clergy get called in, when things go bad, and it's happened a few times to me, is how sacred that time felt, more so than almost anything else. I mean, it's and for me, the only thing that even comes close is doing baptisms, which is that beginning of, usually for us in our tradition, that's the beginning of life thing. We baptize kids in the Methodist Church and babies, and I love baptizing babies, and that is an incredibly special and incredibly sacred time. But right up there was, and I was overwhelmed. Literally, the first time I was like, oh my gosh, what just happened? But it was, I mean, the only word I can use for it is it is sacred, you know, and in our tradition and my belief system, it is. I mean, that is us, you know, returning back from whence we came, to be with God, which is important. And but it's overwhelming. I mean, and it's sacred. It's important, and it should be treated as such,
Yes.
right? Which means you do everything you can, but you want it done with dignity. I think that's the most important thing. That's how you treat it. That's how you treat it.
And it's hard to do that without visualizing what it would look like the other way.
Yeah.
So
I had a person who's brand new to ministry, called me in a bit of a panic because he was visiting somebody who was in hospice care, and it was just him and his brother. And the brother's like, I need to get something to eat. And he's like, I'll hang out with him for a little bit. That's fine. And so the brother went to go something to eat, and the person passed away while this brand new pastor was the only one in the room. And I'm like, yeah, people do that. They don't, especially people who don't, like, I think guys especially don't want to be a burden. Like, I'm sure he's like, well, he was unconscious.
family
And like,
leaves and then they
people,
He
he knew. I'm like, I bet you anything he knew. And it kind of shook him. And I said, look, man, it's like, you can't prepare for it. It's like, but it is a sacred experience. And, you know, you gave him a gift, and in a way he gave you one too. You know, and so it was, it's something.
It's when you know that it's just a vessel.
Yeah.
That your body's a vessel.
Yeah.
That there's a spark that's in there that even when they're sleeping,
Mhm.
that it's still there.
Yeah.
Yep.
Yeah.
So then for our listeners, I think something to really think about, and that's something I'm thinking about too, is actually for my own parents and my sister and myself, because you know, I'm single, so you know, I don't have anybody to make decisions for me if I need care, right? So I need to make sure my wishes are known.
Do you have that?
Do I have what?
Durable medical power of
Of
attorney.
course I do, Jeannine.
Just asking.
Do you?
Yes, I do.
Yeah.
Do you have a living will?
I do.
Good for you.
So do I.
Yes, you do, sir.
And my mom's coming in here in 2 weeks to get hers done because I've been riding her for a while. And I'm like, Mom,
Please.
come on.
It's a gift. It's a gift to those that you know, and you know what they want. It's really a gift.
So here's my final thing on that. I know this is my third final thing. Is I did, and you know, I sometimes as the children, especially once you get to be adult children, if you've got older parents, it can be uncomfortable. But you need to ask them, like, what do you have? What do you have in order? And for me, the final conversation was, Mom, if you think my assumption is you're assuming is that you expect me to be the one that take care of things for you when the time comes that you need things taken care of. She's like, yes. I'm like, great. Then you need to get this done. I need to know what you want. It needs to be written down. We're going to do this the right way. Otherwise, I'm not going to say I'm not going to do it. I mean, you can't say, you know, but it's like, I need you to do this for me. I mean, for yourself, but I also need you to do it for me. And so sometimes if it can be up to the children or the spouse or somebody to go and has to be the one to start the uncomfortable conversation to say, what do you have? Where is it? What, you know, because I want to make sure that I can do everything that you want.
Yep. So gather your families, have these conversations. It's going to be uncomfortable. That's okay. I've talked about having an event called Death Over Dinner.
No, those are
Which
things
is-
that people do. They
Yeah,
do.
which is a way of making light of it, but actually having the serious conversation too, and not having to be so heavy. But, you know, I think it's fun ways to do that. But Ron, thank you very much
Yeah.
for your
Yeah,
passion
welcome.
and for your
Thank you for
education.
having me.
And I think it's an important topic, and I think it'll definitely help people have that dignity at the end.
Yeah. Not our most uplifting episode, but
No.
definitely one of the more important ones because it's something we're all going to have to deal with for ourselves and others at some
And in
point.
the end, like, it really is something that's beautiful. And if you do talk about it, it can be amazing.
So if you would like to passive-aggressively prompt your loved one to think about this, consider sharing this podcast episode with them. You can send it in an email. You can text it to them. Hey, Dad. Hey, Mom. Hey, sister. Take a listen to this and tell me what you think. And, of course, you know, like, subscribe, do all of the things, and let us know if you have any questions or follow-ups that you would like us to talk about. Jeannine, thank you so much.
Thank you.
Thank you.
All right. Thank you, Roy.
Credentialed Wealth Advisors is a Securities and Exchange Commission registered investment advisor. The content provided is for informational purposes only and should not be construed as an offer for investment advice or the purchase or sale of any security, insurance, or other investment product. All investments involve risk, including the potential loss of principal. Before implementing any strategy discussed, individuals should consult with a qualified financial, tax, or legal professional. While the data presented is sourced from materials believed to be reliable, its completeness and accuracy cannot be guaranteed.